We're kicking off our 2023 DISC seminar series by welcoming visiting scholar Dr. Petra Dannanpfel. We'll be hearing from Dr. Dannanpfel in just a couple of minutes. If you're able to, I know we're using a webinar format today, but if you're able to share in the Q&A where you're joining us from, your name, and if this is your first time or you're a returning participant, that would be wonderful. Okay, people are unable to use the chat, but I think you might be able to use the Q&A.
So I just updated, yes, okay, great. I just updated the chat settings. I apologize, everyone. So you are able to use the chat function.
Oh, that's beautiful. I'm typing in my introduction as well. Hello, everyone. My name is Nicole Stadnick. I'm an assistant professor in the Department of Psychiatry at UC San Diego, and one of our co-directors of our Dissemination and Implementation Science Center. So again, oh, is someone talking? Okay. Again, welcome everyone. We're kicking off our 2023 seminar series today. And again, if you're able to in the chat, go ahead and introduce yourself, where you're joining from, and if you're new or returning. All right, let's move on to our next slide. Oh, great. And if you're able to sign in, that would be very helpful for us just to keep a log of who's joining our seminar series. Can you put that in the chat as well, Kara, if possible? I know we're asking a lot of you right now.
I can definitely do that, yeah.
Okay, we appreciate all of your multitasking. It's wonderful. And I'm seeing a lot of returning participants, which is great to see. Welcome back. All right, let's move to our next slide when you can. Oh, thank you. There's a sign-in link in the chat that Kara just posted. Appreciate that, Kara. Okay, so our agenda for the next hour or so, right now we're doing introductions and a few announcements. And then we're going to turn it over to Dr. Petra Dannanpfel, who's visiting us from Sweden, to learn about challenges and opportunities in Swedish healthcare and implementation. So that'll take us to 3:15 today. Okay, next slide. So we have 3 events and opportunities that we would like to share on behalf of the DISC. And then we definitely want to hand it over to you all to share any news or announcements. So the first here, and I don't think that Dr. Borshka Rabin is on the call. I think she's teaching right now, but I'll announce on her behalf the DNI Science Graduate Certificate Program offered through the University of Colorado and Anschutz Medical Campus. They are opening up the application cycle for their certificate program. I think it's open January 15th, so earlier this week, and it closes in a month, February 15th. There's a link there if you're interested in applying. They provide more information too about the number of credits that you'll receive, but overall the program aims to equip participants and students to push the boundaries of health services and public health research and make a lasting impact on population health in diverse settings. So this is a really nice opportunity if you'd like to receive more formal and intensive DNI training. Our second opportunity that we'd like to share is that the DISC is accepting applications for internships. These are primarily for UC San Diego undergraduate and graduate students. But please let us know if you're interested and you're not a UCSD student. We may be able to come up with a plan for you. The link for UCSD students is included there, and we're accepting applications on a rolling basis, and there are opportunities to receive course credit if you're a student. And then finally, we just wanted to announce for next month, our February DISC seminar series will be led by Dr. Bonnie Kaiser at UC San Diego and Dr. Kaiser's colleague, Monique Hinnick. They'll be talking about saturation of qualitative research. This is often a topic it's of high interest to me, and often we get questions about what does saturation really mean? How do I talk about it in my papers and grants, and what does it really mean practically? So we're excited to welcome them next month. So I think with that, I'll pause now and open it up to others. I think unfortunately only the panelists can unmute right now, but if you do have other announcements, resources, or events to share, please do include them in the chat. Oh, I'm seeing people joining, I think, as participants. Yeah, that's great. So I think everyone is now able to unmute if you have anything to share, any resources, grants, papers, announcements, opportunities. All right, well, if anything does come to mind, please do feel free to share it in the chat. And I think with that, I'm going to maybe turn it over to Dr. Ahrens to introduce our presenter for today. So Dr. Ahrens, take it away.
Thank you. So I'm so excited to have Petra here. We met originally in 2018 when Petra came to visit with Per Nilsson and presented me with her PhD dissertation that used some of our work from here in the United States. It was just very exciting to hear. And Dr. Dannanpfel is a PhD in implementation science and is head of change management and head of research in the Department of Health and Care Development in the region Östergötland in Sweden. And the region, it's like a large county, the regions in Sweden. What I find kind of most intriguing about Dr. Dannanpfel is that she is a true scientist practitioner of implementation. So not only does she head units that do implementation, but she's also conducting high quality implementation research along the way. So can really speak to both sides of the equation of research and practice. And that's not that common. So I'm excited to have her here. And with that, I will turn it over to you, Dr. Dannanpfel.
Thank you so much, and for that introduction. And thank you for inviting me to have this talk. I'm happy to be here. I just noticed a problem on my computer that is going to restart within an hour. I tried to snooze it, but just won't listen. So this is not happening. But if I do disappear, you know why. I tried to snooze it like several times now, but so I better keep on going and have my talk. And please, if you have any questions, feel free to interrupt me during the way. Maybe you can put the questions into Q&A or raise your hand.
And then we'll monitor the chat and the Q&A in case there are questions, and we can let you know.
Yeah, so the problem is that I have this the software box here that is going to start over again in an hour, so I cannot see where to start sharing.
Petra, would it be helpful? Would you like to email it to Kara, and then Kara can share her screen? So if you do drop off, you can just call in.
Yeah, I could email it. Actually, I think that Greg has it, so maybe you can
forward it to Kara.
So I do like this now because the box that's about restarting of the computer is blocking my site here. So is this okay with you if I have the slide like this?
Yeah, that looks
works
okay.
for me. Mm-hmm.
Because I don't think I have your most current version.
Okay. So, but that will do, Greg. If you send it, that will be fine. Okay, so I better start now. So I'm going to talk about the Swedish healthcare and combining implementation, practice, and research. And as Greg told you, I'm both an implementation practitioner and also a researcher. Then this is Sweden. I think most people, while I'm here and I said I'm from Sweden, it's like, oh, it's so snowy. You have snow when it's cold in Sweden. And that's, yeah, we do have that up in the north. In the south, it's more like muddy and rainy right now. So this is me with my horse. So sometimes we have snow, then we're lucky, but that could be every other week. We have snow and then it's muddy and rainy. So a little about me. So I started researching implementation science 2010 and had my PhD 2015. At the same time, I did my PhD, was a PhD student. I also had a position as manager over research and development, working about taking care. I had a responsibility for agreements and contracts, strategic investments, follow up on production of research in the region, in our region. And I would use the abbreviation RÖ for County Council of Östergötland because it's such a long word. So I did that for 5 years when I did my PhD. After that, I started to work at Karolinska University Hospital. First as a manager over quality and patient safety. But then Karolinska was at the same time undergoing major changes. It's actually the biggest changes in Swedish healthcare history. So they did change almost everything, from building a new hospital, moving all the operations from the old hospital to the new hospital. They also went from a hierarchical organization to a full matrix organization. So from the beginning, they had divisions and they had clinics that most hospitals have. So when they did the major change, they only have patient pathways. So they only work with processes that are, and they have themes, and all themes have different pathways, patient pathways. So a lot of changes, and they also wanted to have like a new philosophy, the new operating model, meaning that the care will be more centered around the patients. So you had your management team that had responsibility for patient flows. And one of the key components in the implementation was to actually have a patient or next of kin representing in the board group, to always have the patient's perspective included in all the decisions taken. So this is ongoing at the same time when I started at Karolinska, and being an implementation science researcher, this is so interesting for me. So I started to work with just doing the implementation work on a quite operational level under 4 years. And since 2 years back now, I'm back in the County Council of Östergötland, RÖ, where I have when I'm manager over a unit with change experts, change leaders that actually do both smaller and large scale implementations in our hospitals. So we'll talk more about that later. So this is just the context. So Sweden is approximately the same size as California. Even though we have less population, we are 10 million, you are 40 million. So we have more space. And we have 7 university hospitals. A university hospital is of course, they have the healthcare, but it also conducts medical research and training of various professional groups. Then we have the county hospitals that have most types of specialist clinics and also advanced medical equipment that cover most of the hospital areas. Those hospitals operations are mostly conducted as inpatient care. And then we have the foundation, around 1,200 healthcare centers that are in primary care. And they are the part of the open healthcare system in Sweden, and they provide care to the most of the patient's needs that don't require the hospital's technical or medical resources. So we have 21 regions, and they're largely tax financed, and we have responsible for all the healthcare in Sweden. So we are governed by legislation and principles based on decisions of the Swedish Parliament. And as I said, the healthcare system is mainly publicly financed and managed. So the bulk of the hospital sector in Sweden is owned by the government. So the formal responsibility for providing healthcare, since we have 21 regions, is decentralized. So each region have their own regional council and their regional chief executive that together with the managers of the production units have the responsibility to ensure that results are achieved according to the assignments of given by the politicians. And the cost for patients are mainly paid by the tax system. So therefore, our patients only pay a small fee for every healthcare visit, and there is a maximum yearly cost level about $130. I think if I try to convert it a year, so you never pay more than that amount for having your healthcare. And we may also procure services from private companies. So we do have private companies as well that does that in our healthcare system. So these regions have local self-government. So we have the right to design and structure our own activities based on local needs and the conditions that we have. So just to get you a sense of our healthcare system. And this is the region, the county council in total, because we do have one part that is healthcare, but we also have dental care, the regional executive management office. We have 2 schools, so that's within the region, but I only work with the healthcare part of it, of the county council. And that includes 1 university hospital and 2 general hospitals and about 33 healthcare centers and 12 private healthcare centers. So that's the total council. So we also have the schools and the dental care. So this is just a slide to show you the healthcare and how it's organized. So it's organized in centers that you see different medical areas. So we have 11 centers that we in healthcare that we work towards with the development and the implementation. So we support all these centers. This is really difficult. It's always difficult to explain and try to think how we organize and structure for development, and then try to translate it to what you would call it, but I tried. So if you have any questions, please ask me. So the Department of Healthcare Development, where I'm head of research, we work towards we only work towards healthcare. So we work both strategic, but also very operational. So we have my team, change management and processes. I'll talk about that unit in the next slide. And we also have unit for quality of care that helps with patient safety issues and, for example, investigations in the occurrence of an adverse events due to unsafe care. We have e-health and care systems that educate clinicians in the new systems or e-health or innovations. They also, to some extent, do some implementation. So they also help with some implementation. And the portfolio office that has all our projects. They manage the product portfolio for healthcare and all the big large-scale products that are prioritized by the politicians in their strategic plan. But we also have other projects of importance, of course. And then we have the medical device and technology in IT that are responsible for strategic investment and support and customer service. And then we have the other side, the regional executive management office, that of course also we work together and collaborate with. They have 7 healthcare strategies that are responsible for 4 function areas. So each strategies have responsibility, for example, is business development, and they work more strategic within those areas and more trying to figure out what our next steps would be and how we work with information and data driven, what we need to do. And we also have a unit for test and innovation where you can go if you have any ideas you want to try out in healthcare. There are also private companies that can talk to test and innovation if they want to try something out in our organization. And then also the project office with project managers. Then we have, of course, business developers, care developers, and process leaders within our clinics and within our centers. However, that is unclear how many we have that have those positions. We don't know actually, because we try to ask them, because it would be helpful for us from our organization to collaborate with them when we do implementations, because they work more close within the clinics. So it differs, and it's the head of the department, the center manager that had autonomy to recruit and to decide how many business developers they want and how they want to structure for their development and implementation. So it looks a little bit different between the centers, how they are organized when it comes to that. But they are really important persons for us when we do implementation. So this is my unit, and it started 2 years ago. So the thing they started the unit was to actually have more expert support when doing implementation. So I have 14 employees. They have different backgrounds. I actually only have 1 nurse and 3 physiotherapists. So many of them have been working in other companies and private sector, just as change leaders. So they work 60% with large-scale strategic initiatives that includes 1 or more centers, and I manage those big initiatives. And then they work 40% as support into the centers. So, for example, at the Center of Psychiatry, Emma works, 40%. Emma is on the picture here, so they are 2 of my co-workers. So we have like implementation teams, and this is new. This actually started in 1 month actually, but we already started a little bit. So the thing was to let the experts go in and support within the centers in 40% and collaborate with them about their change initiatives. So we have change leaders in, and we have people from the quality unit and also from IT. So this is a new thing, so we don't know if it works or if it's a good idea or if it's a bad idea. Hopefully it's a good idea. So what we do is that we support managers with implementation and change initiatives. And as I said, it's very on the operational level. So we both work with the center management, but we also work with the first line managers. Often we work with the first line managers and help and support them. We also do process mapping to improve and optimize clinical processes. For example, breast cancer process that you on the pictures work with. And those are, they are big processes involving many centers. So they are very complex processes to work with, but also very fun. We also have education. So we have a 2-day course in change management, theory and practice, that it's for everyone. If you are going to do any kind of change in your clinic, or if you're a manager, so it's both for managers and for business developers. And then we also do a course in the process mapping and method, and then the follow-up and continuous improvement and quality improvement. So that's what we offer from our unit. So I'm going to talk about a little about challenges that we have in Swedish healthcare, and I think we are not alone in the world to have these kind of challenges.
Petra?
Yes.
Petra, this is Nicole. Before you talk about challenges, can I just, I'm curious about this sort of transformation in the structure of the healthcare system. It sounds like it's fairly recent. And you went from a hierarchical structure to a more, you said, matrix structure, and you have these implementation teams, which it sounds amazing. I'm just curious, what was the motivation or the catalyst behind that?
Yeah, so the big implementation when we did went from a hierarchical structure to a matrix structure, that was at Karolinska University Hospital, so that was another hospital. So that was, yeah, and that's a long story because there was an investigation about, it started actually if they wanted to have a new hospital, or if they were to remodel the old one. And then we had this director from the Netherlands, and so the thing is what they wanted to work with value-based healthcare and implement that. So, and he also wanted to restructure and work more with pathways. So there was this was a 10-year ongoing different things that actually add together the hospital thing. That was a decision in 2004, and then they started to build a new hospital. And then Melvin came, was his name, and he wanted to implement value-based healthcare. He wanted to have pathways. He didn't want to have clinics, so he wanted to have more seamless patient journeys. So there were a lot of bunch of ideas. That's a story in itself, a long story I can talk a lot about. But if you ask, if I talk about now the implementation teams that we started in where I work right now, there was actually, we did we scrutinized the new organization. Since my unit is 2 years old, so there were other decisions that actually came up with the idea to have my unit. From the beginning, they only had business developers in the centers. Then they said that, okay, let's start a unit with more expert in change management. So let's start this unit. And there was a lot of other reorganization as well. And then after 2 years now, they say that, okay, maybe we shouldn't have a unit. Maybe we should have them included again in the centers, working more closely. So now we do both. So we have the large-scale implementations that I manage, and we have the whole team. And then we also have the experts supporting in the centers and supporting the business developers in the centers. I don't know if that answered your question. So thing was, they wanted to have experts more closely in the centers all the time to actually see what is going on, and also help them to start initiatives and build a structure for implementation. So both the higher management, but also on the lower level.
That's super helpful. Thank you for sharing those details. Very interesting.
So the challenges that we have is recruitment and retention of staff. That's a big problem for us. And the thing is, all these challenges that we do have, we have a lot of challenges that we need to address right now. So we are fighting fires all the time, but we also need to work on long-term solutions. So then we need to work both short-term with a sense of urgency, but also do the long-term planning. So, and that's a problem since their time is limited. So, so we have the recruitment retention of skilled staff. We don't have anyone to employ. There are no nurses. That's one thing. And what I'm talking about also, the lack of seamless front door and back door operations, the patient pathways, they're not optimized. So we had a lot of work to do there. We also have a slow adaptation to digital transformation. We do a lot of digital implementation, but it's slow. We also have multiple IT solutions that are not integrated or compatible with each other. That's very frustrating for the clinicians when they work. So they have to log in and log out from different systems. And we also have the medically fit patients, or it's often that's elderly patients, so not leaving the hospital because they all mostly they need municipal care, and we do not have a good collaboration between us. So we also need to work on that partnership between the municipalities and the healthcare and the region. So be more centered around the patient and stop thinking about that we are different organizations. So when it comes to recruitment, we know that between 2020 and 2030, the proportion of people over 80 is estimated to increase with 49%. While the proportion of people of working age will only increase with 4%. So we live longer, which is a good thing. But living longer also means that we live longer with chronic diseases. So care needs both increase and needs to change. It changes over time. And the regions currently employ about 6% of working age population. And to maintain that current staffing, we need to employ 38% of the additional working age population. And if you add municipalities, it's 65%. So the equation doesn't add up. So what we need to do is like start working differently. That's what we need to do, which requires a lot of change, of course. Oh, sorry.
Petra, I'm so sorry. This is Nicole again. Let us know if you prefer questions at the end, or if you're okay with questions now.
You can ask me questions. I just stressed about this restarting on my computer.
We received a question from Jessica Aaliyah, who's in our audience right now. And Jessica, feel free to unmute and clarify your question a bit. I'm not quite clear. But Jessica asked, did the group have a list of aims or goals? And I'm not sure if you're referring to the implementation team or the change team, Jessica.
So I think she answered my question when she said that when she went through the challenges, I think those were their aims. So yes, I think she answered my question. Thank you.
Okay. Perfect. Thanks, Jessica. Thanks, Petra.
Thank you. So I continue on the challenge list. So there's also time constraints. We do a lot of activities that not create value. We do too much documentation and too much administration, especially our managers. So that's also one thing that we need to work upon. So we actually had a big workshop called, how to translate that, catch the time thieves, if I just translate it. When we asked them, what takes most of your time? And they said it's the system that doesn't work, administration, documentation. So we have this big project now to look over how can we work better with the systems and documentation so they don't have to do it so much. And of course, we also have everything post-COVID that we need to take care of, long patient waiting lists. And also we need to work better with have a better capacity for large-scale implementations, and also make sure that things are implemented and not just delivered or installed. That's a few of our challenges. But we also have opportunities since we're working on addressing all these challenges. So I'm just going to go through them briefly. So this is some of the projects and ongoing discussions that we have regarding the patients. So it's like having the right patient in the right place, ensuring what I've talked about, the process. The patients are not, the thing is now that the patients need to understand healthcare and they get referral to different clinics. They aren't supposed to think about that. It's supposed to be mere seamless for them. So more that we organize around the patient than thinking about different clinics. So we need to collaborate better between the centers. And also service offered based on customers' different needs. For example, that they can contact their healthcare center using chat or telephone, and how they want to receive the care. Do they want to have video, or if they would like to have a physical meeting? So we try to look into how can we deliver care to our patients based on their different needs. And the workforce, I told you about the challenges with recruitment and retaining staff. So that's a big project that we also work around. And we also have, actually it's from the politicians. They talk very much in their strategic plan about managers as change leaders. That we need to equip managers with skills in doing implementations and leading change, since that's not going to stop. I mean, change is here to stay, I guess, forever. So we have looked into our new, we are just developing a new leadership program and looking how we can integrate this knowledge and skills into this new leadership program. So we from my unit have this 2-day course, but now we want to integrate it in the leadership program that HR are responsible for. So we are in discussions how we can collaborate and integrate that knowledge into the leadership program. So when it comes to organization, these are also a list of activities that we do talk about and that we address in different ways. Speed and capability of adoption of new ways to work. So how do we structure for continuous change to always have this capacity to change and work in new ways? And also we talk a lot about decision based on right information, data driven. What do we want to see in our dashboards? What do we need to know to work more prospective than in retrospective? Also, can we use data to simulate scenarios before decisions? For example, if the staffing during summer, that's always a problem every year. Can we use data in some ways and then simulate scenarios, and so we can be more taking better decisions how to cope with this? And also, what do we need to measure and follow up? We have a lot of data, but how do we use it, and what do we actually need to follow up on? And also tempering, because sometimes we have rare events, we don't need to address them. So and sometimes the problem is a systematic problem, so we need to know the difference. So we need to be constantly there to do the analyze. Is this due to staff being sick, or is this a problem that repeats itself over time? Then we need to do something about it. And then we have production planning, and I will talk more about that because that's a case I will talk about how we do, how we perform big scale implementation right now. So these are some of the challenges, and this is my own reflections from now in our county council, but also from working in healthcare in many years. Often we just we don't motivate the why for change enough. So it's like, here you have this new e-health solution. So they get like some staff meetings and talk about what it is, not why we're doing it. That's the thing. So why do we need to implement it? And also, I think that we move too fast when we do our change. So we need to motivate why. There's a sense of urgency or whatever, or is it a postcard from the future, something that will make us better for patients in the future. So I think that we should spend more time in the initial phase of implementation, like getting buy-in and commitment from our staff, talking about why, include them in workshops, and let it take some time in the beginning. We are always we wanted to make it so fast, So it's like we have a big implementation now. They had an education on Friday, and let's say this project is the national project, so we don't have any saying about the implementation plan. So they have the education on Friday and the start on the Tuesday after. That's too fast. So I mean, and there are not many activities before. I think it's like during 7 weeks. So what they have is like introduction, then go back home. There are 2 weeks to make new, to work with their new routines and how to integrate this. It's a chat function in the healthcare centers. So we always move too fast. So instead of spending time in the beginning and do all this work that everyone says to me always, we don't have time. And I'll say, we don't have time with failure implementation on over and over again either, because we never reach the outcome and that we don't have the benefits of the effects if you move too fast. Then we are caught in the installation trap. So we don't implement it. We just have the installation of the technique. We also do many changes at the same time. So one healthcare center can have 5 implementations and change initiatives ongoing at the same time. That's increased the complexity to understand the why in all these different initiatives. Also, we have change fatigue and also negative impact on persistence and outcomes since we never fully implement something. So we need to stop doing everything at the same time, be more brave and prioritize, and also say stop to kill projects that we see after 5 years, we don't reach the outcome that we wanted. So in that case, it could be either we need to do a re-implementation and start all over again, or just drop the project. And also, we need to have better capacity for large-scale implementation. So we have my unit now, and we have some business developers, but we need to be more. We need to have the better support for large-scale implementations that actually helps the clinicians and doing the change together with them. But we also have to have respect for that there actually is an intrusion in their clinical work. So that's the thing we always try to think about when we go in and do an implementation, is that we know that having a workshop with 5 physicians, there are 5 patients we don't see that day during that hour. So we need to be careful about the clinician's time. So that's why I think that we should have more support from people like me, people like from my unit, that actually can do the implementation together with the clinicians. So, and one thing here is to educate managers, and we're actually doing that now. That's good. So they get a sense of how much work it actually is to do an implementation when it comes to time and yeah, clinicians that are not doing their ordinary work. And also to be better to measure and adjust during our implementations, because we have a one-size-fits-all, and then we just push it out in the organization, and the one-size-fits-all doesn't fit all. So we need to know, maybe be better to measure before and look into the different conditions in the different clinical settings and see what do you need, because some clinics might need more information or more training, other clinics are like, if you're motivated, we know why, just give it to us. So then we don't need to put some effort in some clinics, and that we see all the time. Some clinics are really ready, other ones are not. So if we want to be careful with our time also, put the support to those clinics that actually needs it, because it's not everyone that needs the same support all the time. And also follow our implementation process during the time that we implement. So we often implement and then we do nothing, and then we expect it to be implemented. So and then we see, oh, it didn't work out. So why? So be more active in measuring and follow up during the implementation process. So this is I'm going to talk about my case now about production control. So what we did was we had 3 workshops with the highest management, the center managers and the directors. So it was me, and it was Myrna, and she is doctor in mathematics, and she's the brain behind the production planning model. So we asked them, what do you spend most of your time on today? So they got this picture, and then we talked about it, and there was they spend the most of the time on firefighting, fighting fires, crisis, pressing problems. And that, of course, is a problem for long-term planning and long-term thinking, and actually solve the root cause of the problems that we have, because they need to fight fires all the time. So, but we need them to spend time on finding new opportunities, new solutions, and the long-term planning, so that could actually solve a problem in the future. So this is the case, just to make it maybe more practical how we do this. And this is also, of course, there are many details in it, but so we have this production care planning, and it's a large-scale implementation in all clinics and healthcare centers. So everyone's going to do this in the end. And production control is the foundation in healthcare, because we need to know how big the demand for care are, both when it comes to inpatient, outpatient, and surgical care, to be able to plan for our capacity based on the staff that we have, or operating theaters, or etc. So we need to have control over this. Otherwise, we just do things like the quotations that you see there from clinicians. I'm doing the best I can, we'll see how far it goes. They have no idea, what do I need to do a day? So our current planning has several problems. One thing was data structure for planning. We had no standardized reports or dashboard to follow up on performance. Of course, we have data, but it was unstructured. Lack of communication between the different clinics. And we need to have a better collaboration for relocation of resources to better fit the demand between us, for example, when it comes to surgery. And the existing planning process was reactive and left little room for actual planning and reallocation of resources. So we reacted, but we're not planning. We just react all the time. So the last 17 years, different initiatives and projects have tried to implement and address these issues that I just mentioned, but we have never reached full implementation. So this problem has still remained. So this new project have a really strong buy-in from leaders and a strong support, which of course will help us to do the implementation, and also to have their buy-in and sponsorship, and talking about then about what conditions, what are your conditions, and how can we help you with this implementation. So we have worked together with the team for product planning, and the team for product planning has developed the standardized reports and dashboards and tailor them to each clinic. So they have a weekly production plan and daily production plan, so they know the rate for each category, what their production each day and the pace will be. How many patients do you need to see a day? Okay, yeah, so what we want to do is to go from our current situation, which is our power mission. We have no idea, we just work, we don't know. Is the waiting list still there? Yes, it is. So what we need, so we need to know the future state is, I have done what I need to do. So I know this is the pace, I have to see 10 patients a day. And stop focusing on the waiting list. Don't care about the waiting list. Focus on the pace, the patients you need to see or operate today. So from short-term planning to long-term planning. So this is what we want to do. This is a shift. This is how it looks. This is a report, for example. So if you want to, this is the pace for one clinic. So they had a waiting list, 80 patients. So to reduce the waiting list, we need to see 11 patients a day. Then you know, as clinicians, I need to see 11 patients a day. When we have balance, when we have no waiting list, we need to see 10 patients a day. So this is what I get to help them with the planning. And as I told you, we've been working very close together, the team production planning and my team. So we've been working on the why, the communication plan to staff and to managers. So we are doing like communication plans that managers can use to talk with the staff with. So what do we want it to feel? What do we want it to do? So we've been working really close in all the aspects of it, just from the what is it, the solution, and also how can we integrate the solution? Who are going to work with this solution? So from the beginning, they have worked as a team. And I think that has been very successful because the team change management have quite a high knowledge about production planning and what it is, and team production have a good insight in what do they need to do for the implementation. So this is I think very good. It's the first time actually that we have been working so close together. So this is the implementation plan, the general time plan, the time for the implementation. So I told you that me and Myrna had the workshop with a okay, it says my computer going to turn off in 10 minutes. I don't know why I cannot snooze it. Just stuck here. Okay, so this is the implementation plan. So we have activities. So it's the support from change management and the production team, production planning team. So we meet with the higher management, the center management, and his team, like his HR officer, so that team, and also the manager for the. It's not on the clinical level. It's like a manager for several clinics. I don't know how to translate that. And we have 4 workshops and kickoffs when we talk about what help do you need, what are your conditions. It's also up to higher management to give us the timeline for which clinics that we will start with first. And it can be of different reasons. It can be a sense of urgency that they have a long waiting list, so they need to start doing this now. But it can also be clinics that are very ready to do it. They want to start working with production planning. So we let them decide. Because we don't have a clue. So we start workshops with them, and then we coach them all the time. And then we have the clinical work group. So we have the first line manager. And then we have a series of several workshops. So, and what we ask the higher management or the center manager is to say, you own this change. We don't. So you need to be the one that did all the communication. Why? So you need to talk to your managers and say that you support this change. And then we go on the next. Here. So this are the workshops that we do together with the first level manager and his team or her team. So the manager decides who needs to be on the local implementation team, and then we support them all the way through these workshops. So we have the yeah.
That's right. I just have a question. So when you talk about, create the plan for production, does production refer to like patient flow, number of patients seen, or just what does it mean in this context?
Yeah. Production planning is, so we need to know, for example, how many surgeries do we need to do each day to manage the demand from patients. Mm-hmm. And that's the imbalance that we have today. So we have a long waiting list. Do we need to cut the list? So for maybe 20 weeks, we need to see 11 patients a day. But when we've done that, the pace is 10 a day. So it's the foundation of how we control and manage all the care in the hospital. So that's the implementation object is the standardized report, and also of course how do they work different and how do we collaborate. So there's a lot and many things that comes with it, but it's the foundation, because there's a big problem that we don't have that control. So this is more detailed view of the workshops that we do, and it's about one implementation. First, we start with the higher management that was on the other slide, and going through this workshop series is about half a year. But if you go on this level, the clinical level, it's about 3 months. So you do one workshop, then we get back 2 weeks later. Then the first one is and that's a lot of the first workshop is to create good condition from implementation. It's the kickoff meeting. So what do you need for support? What kind of workshops do we need to do together to see how you can change your routines, and what do you need to work with to have this standardized reports and dashboards integrated in your daily work? Because this is what you're going to do every day. You need to look at this dashboard every day. And if you don't have the pace of 10 patients, you need to ask why. Why did we only see 8 patients today? So there's also setting up the structure for continuous improvement and do the PDSA cycle in the end. And then we have the 2 first workshops are more about the conditions and do an analysis of the current status in the clinic, both when it comes to what behaviors do we need to change, what routines do we need to do, how do we need to change the way we work today. And all this is a collaboration with the clinicians. And then the 3 next workshops that are more brown here, it's the production planning team that go home, they look at the reports, they look at the data for the specific clinic, and then they come back and talk about, this is your report. How do you feel about it? Here's the numbers, here's your pace. Then it's more detailed. This is what you need to do. This is the pace you need to have. And also, of course, one thing that's really important is the scheduling, the planning, the staffing, because we need to control that. And that's one thing that the physicians always, they don't like it because they don't want to be scheduled. So that's one thing that work. Everyone needs to go on the schedule. And then we work together with them to plan for the follow-up. How do you continuously follow up on this? Who are responsible if there is just 8 patients that have today? So I mean, if you see that last week, Monday, Tuesday, Wednesday, we only saw 8 patients, we were supposed to see 10. So what happens? So we also talk about what roles and what functions do you need to have to always analyze and feedback and then see what you need to do different. And that's what I mean about, is this a rare event, something that happened because of the people were sick, or do we actually see over several weeks that we cannot keep up with the pace? So then we need to look in how we work again. So we need to, I mean, continuously improve the process. So we do. So these are the details of the different workshops that we do, and then always, how do you work with the gap? And then we have a closure meeting, and then we actually, of course, we can support them again. But the thing is, after those workshops, they are supposed to have the structure for follow up, have the new routines, have the new ways how to work, have the roles and functions in place, and then we leave. So they're on their own, but of course we can support them again. But there are many clinics that we need to do. I think it's in this first implementation we do, it's about 80 clinics, and it's going to be more. So this is something that we also talk about especially when you talk both on all manager levels, we talk about this. We talk about that the change is temporary. So we lead change and it's temporary. We have support, we do activities, but that's just for a certain time. So we actually, what we do need to see is continuous improvement as administration. That's something you need to do all the time. Otherwise, if you set up a really good process, and then after a year, maybe it's not so good anymore because we have done organizational changes. There are different needs from patients. The staffing looks different. So what we want to do is build structure for learning and improvement and how to learn, how to improve. Like, how do you look into your process? How do you take care of bottlenecks? So we also want, when we go in and do these implementations, that we hopefully they have good experience from we helping them with the setup, and then maybe they can learn and also do it by themselves. So we try to look at the whole chain from the temporary to, okay, here's your administration. This is what you need to do. You have to have those functions and those roles and the content in that function. So you actually can have this continuous improvement all the time. So we see that as administration or monitoring or management or what you want to call it. So yeah, so that's about it. I think that my computer will start working in like 20 seconds. So any questions?
Yeah, I think I have some, but I want to open it up to the group. I'm just holding my breath to see if your computer really shuts off.
Yeah, me too. And it's totally locked. I cannot even do anything.
Well, I guess that answers that question. So why don't we give Petra a few minutes to restart and join. And I think one of the things I want to ask her is, you know, in this very complex process that she was describing, it seems like there would be multiple implementation strategies that emerge from that work group that's looking at that process improvement. So I'm just wondering what some of those strategies might have been and how they adapt. So I think many of us who do implementation work have to struggle with the adaptation. You know, you come in with your implementation plan and things may change in the context, or in the case of what Petra was talking about, it's a group of people from different departments, like from HR, from surgery, from computer science or the electronic health record, coming together to look at these processes. And I know, Nicole, you've dealt with a lot of that complexity, and it's very difficult to just come in with a plan and not have it. I don't know. I'm just thinking of like when you make bread and you have to knead bread dough. you're trying to come up with this perfect loaf, but it just takes a lot of working the dough to get there. So
I did love that she mentioned that there's someone from IT on every one of those implementation teams within the centers or clinics. I mean, that's so necessary and brilliant because you can't really do much without IT.
yeah.
You can have all the great ideas, but without IT to bless it and to make sure that it works, it's not going to happen.
Yeah, well, I also liked that she mentioned HR. You almost never hear talking about HR departments, and in almost every case, the work that I've done, you know, the workforce is a huge issue, and we're always talking to like clinical supervisors or team leaders, but rarely to HR departments. And I know that, for example, in our interagency collaborative team project, job descriptions were adjusted by HR departments to take into account the new practice that was being implemented. So it's not just we're just trying to shift stuff around, but it actually was put into the, you know, the HR process and the HR function. which I think we just don't think about that much. Or I need to pay more attention to it. I know that. I wonder if others have some experiences like that.
Hi again.
Oh, we're here. You're back. So we're just
Yeah, I'm back.
we're just talking about how, especially like in your workshops and working through these things in order to change the implementation process. I was wondering, because it seems like there's an opportunity for lots of sort of micro implementation strategies to be developed, as problems or issues get identified. How do you manage sort of the emerging different kinds of things that the group wants to try to improve that process?
Yeah, it depends on if we are involved, because there are a lot of things going on all the time that we have no idea about what's going on. But if it's something that often it's, what you are going to implement. For example, if it's a chat function or if it's a new guideline. So if I understand you correct, Greg, so you ask how we cope with the clinician's idea, or if you want to do something else, or.
Yeah, so your process, sort of your group process, is a big implementation strategy.
Yeah.
But then, it seems like, if HR is involved or if IT is involved, little things will be added or adjusted. So I just wonder how you manage that process.
Often when it comes, so IT, of course, are involved when it comes to the technical solution. But when we, and that's one thing we need to work better with, is to, when we develop a solution, often we buy something in. And that's a problem also, because when we do that, the clinicians say that we don't have any need for this new technical solution or whatever it is. Yeah. But often we don't have to handle the, often we have a fixed solution that we are to implement. And then we say, okay, if we can't change the technique, how do we integrate the technique and get it useful for us? And then we are very open when we go in and work with the workshop with the clinicians and say, okay, hey, this is we're going to have a new way to contact you in the healthcare centers, and that's the chat function. So what would that mean for you? And then they decide themselves, it's like, do they want the same nurse to be chatting every day, or do you have it like half of the day and then you change? So the process and how they work, we're totally open for how it looks in the specific clinic when we do it good, so to say. So when we go in and work, we say, okay, this is, we motivate why, but we always ask the manager to do that, because we have no mandate. So we always say to the manager, that's one of the demands that we have. You need to support this change. You need to talk about the why. We can help you with your communication plan, but you need to be the one that address the change. So then we set up, okay, this is the thing that's going to be implemented, or we have a new guideline in sepsis. Okay, so we have worked with many of these standardized processes and guidelines that we're going to implement now. So then we start with different workshops. How do we look today? Okay, if we're going to do it this way, what do we need to change? Are there other clinics that impacts this change? Then we need to involve them in the workshops. So we have all the stakeholders involved in the workshops. So that's how we start. And then we go everything through. So, and if we need one more workshop to talk about, then we set up a new workshop. But we try to be careful with the clinicians' time, of course, because they don't have time to be away from their daily work so much. But we're very open, because they know how it works. We don't. We can. What we say is that we can help with the methods. We can help with the facilitation. We can talk about what conditions that are good, but that's all our knowledge. The rest of the knowledge are the clinicians. So that's our take when they go in and do changes, to get the buy-in and get them committed, and the feeling of that they are the ones that owns the process and owns the change, not we.
Yeah, I think that's so important from an implementation purveyor or an implementation supporter, that you're helping them to do the implementation, but you're not doing it and then just leaving. And I know that in one of your slides there, you mentioned that you wanted lasting change, not change for this that would go away. This idea of going into it with that lasting change, which I really like.
Yeah, because that's but that's a problem we have. We have, for example, self-monitoring of blood pressure and asthma. We have that installed in all the healthcare centers, but it's just like 7 that actually use it and have patients connected to this self-monitoring. So that's what we call the installation trap. So we could tick the box. We have the technique, and that's also, I think, when I've been on different workshops with directors and the higher management, they say like, "Oh, this is all implemented everywhere." It's like, no, it's not. It's only 7 healthcare centers that use it. So they have this naive thought about, well, if we just tell them to do it, they do it. That's not the case.
Yeah.
So, and that's when we come to scale up also, because we actually did a survey to all healthcare centers about self-monitoring. And what we could see that the healthcare centers that actually had more than 100 patients connected to this to do this self-monitoring, the staff saw the value of it. They saw the benefits of it. They think it was fun to work with. They felt secure and safe to talk about the patients about self-monitoring instead of going to physical meetings all the time. That's why we need to scale it to see the benefits, both when it comes to outcome, but also when it comes to among the staff. Because if you only have 2 patients, it's like you never do it. So you don't maybe talk about it, or you don't feel safe doing it. So that's the importance of scale up.
Yeah. So yeah, I'm impressed with the work that you're doing, given the complexity and your role. So it's very interesting and exciting. We are at time for our seminar, though, I'm sad to say. But if people wanted to get in touch, are you comfortable with us sharing your contact information?
Yeah, of course. Maybe I could, I have it in the last page on my slide. Maybe I can put it in the chat. Is that okay?
Sure.
Can everyone see that?
And then we can share it if anyone asks as well.
Yeah. And you can also have my slides if you want to.
Oh, thank you. Yeah. So any other wrap up, Nicole? I just want to make sure I'm following protocol here. I think we have the evaluation link in the chat.
Yes, it's less than 1 minute evaluation. It's just one question. Petra, thank you so much for joining us today and persisting through your computer restart and update. Hopefully it runs smoothly now.
Yeah, I'm so sorry about that. That's it. Yeah, that's a standard thing for me and technique and computers. It's always something. I don't know why it is.
It's not